My name is Dr. David Schwartz. I'm an orthopedic surgeon at Ortho Indy in Indianapolis, and I'm going to speak to you today about choosing a practice, primarily looking at private practice, but also discussing some of the options out there in academics. So currently, there's several different types of practices. There's the solo practice, a small group, which could either be a single specialty or multi-specialty group, a large group, or a hospital-based practice. First, discussing solo practice. There's good news and there's bad news about it. As a solo practitioner, you're the king of your castle and you get to make all of your own decisions. But then the bad part is, you're also the king of the castle and you have to make all those decisions. That includes business, patient care, and just running the practice itself. Looking at group practices, there's several different things you need to consider. And that doesn't matter if it's a large group or a small group. But you have to look at the different types of personalities, responsibilities, looking at the relationships with your partners, and just in general seeing, can you get along with other people? Looking at a single specialty group, the question is whether or not there's a framework already set up for you to exist there. Are you joining an orthopedic group or a neurosurgical group? Are there other physicians who are doing the type of surgery that you do? You really want to have that framework there in the first place. Additionally, what type of responsibilities are you going to have to perform as far as administratively, as far as business-wise? Exactly what is that going to get you involved into in that solo small group practice? And when I say small group, I usually mean 3 to 5, 3 to 6 practitioners. The next question is, with a small group, is it a multi-specialty small group? That is, are there other physicians of your like specialty or other specialties that are hiring you to take spine care of their patients? One of the big problems is if there's not been another spine surgeon there in the past, are you going to have to develop all of these new referral patterns? Are your partners hiring you just because they want somebody to give their back pain to? Or are there really referrals for true spine surgical patients there? Also, why are your partners hiring you? Is it because there's a need to fulfill a type of insurance product, or do they really, really need you? It's very important to figure that out. Looking at large groups, and these are groups where I would say there's between 10 and 30, 10 and 40, 10 and 50, 10 and 60 amount of partners. There's very different ways that they're set up. There can be the subspecialties, which can include a spine division. This could be made up of both ortho, neuro, interventional physicians, as well as non-operative physicians. Then you're also going to have your administration. You'll have your physician representation. And one of the issues you have to look at is the overhead, and typically on these patients, overhead is somewhat higher. However, it also allows for significant business opportunities. You can have ancillaries including physical therapy, surgery centers, MRI, and physician-owned hospitals. Additionally, in these large groups, you're able to have research foundations, research coordinators, collection of data, and collaborative studies, which in today's medical economics is becoming more and more important to show the value of what you're doing. Next, looking at hospital practices. There's several different things you have to be aware of. Initially, they're offering very large salaries. This looks great, especially somebody coming out of residency and training that's got $500,000 to $600,000 in debt. However, remember, there's very little autonomy. You are joining as a worker for another large organization. You're an employee. Beware of hidden overcosts and hidden overhead. Beware of the second contract. Oftentimes, the first contract is really very good, very attractive. Many people are overwhelmed by the amount of money that's being thrown at you. However, the second contract you get, usually there's a significant decrease in the amount of money that's being offered to you. Know who you're competing with in your own community. Are you going to be hired by a hospital to go against a group that's been there for years with significant expertise compared to your own? Can you really compete with them? You need to know if you really have that opportunity to make an inroad in that community. Again, remember, salary is not always the most important thing. Initially, the salaries are usually very high. It's almost a bait and switch versus do they really need you? Look at those contracts. They may be offering a significant amount of dollars, but when you actually go and look and see how the overhead's calculated, it may end up at the end of the year that you actually owe them money if you have not performed the services they had written into the contract. And remember, hospitals profit from you. Be aggressive when you negotiate these contracts. They make money off of you in the surgical fees, in the ancillaries, when you send a patient to physical therapy, when you're sending patients for MRI or imaging, they allow them to be full service by having you. So don't sell yourself short. It's very important that you realize that you're important to them. But the one thing also to remember, while these first contracts are high, oftentimes the second contract isn't. You've probably heard throughout the country hospitals are letting staff members go. Recently in Indianapolis, I'd say the 3 different hospitals we have let over 1,000 employees go at each hospital. And that's because they've given physicians, they've bought these practices, which cost them tremendous amounts of money, but it's not generating any new revenue. And now at the end of the year, they're caught short, excuse me. And by being caught short, they have to make that up somehow, and they're actually on the short term letting employees go. Not physicians, but employees who work in the hospital. But that affects you because if there are less nurses, less OR staff, that can make your life miserable. So realize everything has a cost. And if something looks too good, it probably is. With regards to compensation, it's my belief that making your decision for where you're going to practice strictly based on compensation is the wrong thing to do. You need to understand the compensation models so you know what you're getting into and you're not upset later on thinking that you were promised one thing and receiving another. But you really need to look at what's the right opportunity for you, both clinically, professionally, and personally. And remember, when you're discussing compensation with groups, most groups have been established for quite some time, and they've arrived after years of discussion of what their compensation model is going to be. Don't think you're going to come in there and be able to change it for them immediately or at all. Back in the 1990s, compensation models were fairly complicated. Physicians were paid by what was managed care and how the group participated. Oftentimes, a group would want a physician or surgeon specialty to be in that group just so they could get more money from the managed care program. Things have changed a fair amount today's situation. But what you really need to understand is in the region of the country or the city you're looking at, it's not likely to be a wide variation from compensation structures from practice to practice. It's market economics. Most practices will offer about what the other practices are doing. It has caused the initial contracts to go up in private practice to keep up with the hospitals, but pretty much for the most part, where you're going to be looking, whatever city or region, it's going to be fairly constant. With regards to compensation, the prevailing model is salary or net income guarantees with some type of bonus. What's the incentive for the bonus? It's important to understand what the group wants you to accomplish before that bonus will kick in. The next thing you want to know with regards to that bonus is how high is the bar? How much do you have to earn before you'll be able to get that bonus? And you want to look at the group and say, have others in the group been able to achieve that bonus? And I would recommend going to some of the younger members of the group and actually talking to them and get their feelings with regards to actual numbers that they could obtain during their first years in practice and whether or not they were able to achieve that bonus. Other compensation methods are either straight salary or productivity. And this is based on looking at your RVUs and billings and collections and then figuring out your overhead and then determining what your salary would be. That gives you a bigger upside where you can actually earn more money. However, you also might not earn as much money as a straight salary. You're basically hedging your bets, and the best thing to figure out is what's good for you. The next thing to think about is partnership. What does it require to become a partner in that group? All of you out there want to become partners. You don't want to be the transient physician who moves from place to place. You want to look at what are the ancillaries? Can you participate in them? That can affect your bottom line. And some of the questions are, when can you participate them? Do you have to wait to become a partner, or can you participate them before? How much will it cost to participate in them? Those are all things to ask when you're discussing the contract. Also looking at the call schedule. Will you be taking the same amount of call as other physicians in your similar subspecialty, or will be more call dumped on you? That's something you may or may not want. I would say for the long term, it works out better if it's a fairly equal call schedule. As a young partner, you may be asking your older partners that, can you take some of their call? But after a while, if you feel like you're taking, say, 2/3 of the call and the other partners are taking 1/3, that becomes old. Also, what's the office location going to be? Do they know where you're going to be placed, or are you going to have to move from office to office? Right now, I would say in the current medical model that we have, an economic model, road running is fairly common. I'd like to tell you a little bit about my orthopedic group. I think it entertains some of the things that are in all of these groups, considering that in 1962 it was founded by 2 orthopedic surgeons, so it was a small solo group. In 1995, when I joined the group, there were 30 orthopedic surgeons. 2011, we're up to 70 orthopedic surgeons, 9 pain management physicians, and 8 anesthesiologists. Currently, we give complete subspecialty orthopedic care, and in that we have spine care, which includes orthopedic surgeons, and now we're actually hiring neurosurgeons as well, so it'll be a complete multi-specialty spine division within our group. We have a complete orthopedic research foundation, which is self-sustaining, and anytime we want to develop any type of research projects, we put a grant into our own research foundation. At OrthoIndy, we have complete orthopedic subspecialty care, and now in our spine division, not only orthopedic surgeons and interventionalists, but we're also hiring neurosurgeons to come work with us. We feel there's a complete spinal foundation for a spine care service the way we've set it up. Additionally, we have our own research foundation. If you're interested in doing research, but not necessarily being in an academic setting, by joining a very large group, you're able to complete projects with a self-funded research foundation. We just applied our own foundation for grants, and if the foundation service believes that it's a worthwhile study, we're funded. We also have fellowships in spine, trauma, total joints, and sports. At the Indiana Orthopedic Hospital, which we were able to build ourselves, we have 10 ORs, 44 beds. We own 2 separate ambulatory surgery centers. We own physical therapy at 4 different locations, 4 different locations with MRI units and CT scanners. We own our own pharmacy, and all spine orthopedic procedures are able to be performed at the Indiana Orthopedic Hospital. Additionally, we have our own O-arm and all up-to-date equipment, better than I would think almost all hospitals that I've ever worked at. So with that, what I would recommend is to really choose wisely. Think about what you want to do, what you want to accomplish professionally as well as personally. Can you work with others or not? And then think about it, take your time, and pick the practice that's right for you.